I'm an American board certified OBGYN, a mom, a Muslim, and I'm talking about sex. This is the Muslim Sex Podcast. Welcome to the Muslim Sex Podcast. I'm your host, Dr. Sadaf, and this episode is everything you need to know about your bones, your muscles, and how to live well into perimenopause, menopause, and all the things that you need to do to keep functioning. Before we get into this episode, I want to make very clear that we're not giving any type of medical advice. So if you have any questions about your health, make sure you go see your healthcare provider. And of course, like always, this is not any advice on your religion. So if you have any questions about your religion, make sure you go see your friendly neighborhood religious leader. And this is the Muslim Sex Podcast because I just happen to be a Muslim woman that talks about sex. I am super excited to have on with me today Dr. Wittstein. Yes, Dr. Wittstein comes to us from Duke University. So, Dr. Wittstein, please, if you could just introduce yourself to all the viewers and listeners out there.
Sure. I'm an orthopedic surgeon. My fellowship training is in sports medicine, but one of my, I would say subspecialized interests is the intersection of women's health and orthopedic health. And I take care of female athletes from, adolescents through masters athletes. I am also an associate professor, so I train medical students, residents, fellows, and I'm a researcher. So I do some NIH-funded research. I collaborate with other PhDs on issues related to joint health, a lot of it cartilage-related, ligament injury-related, and much of it related to the intersection of musculoskeletal health and women's health in menopausal women.
Amazing. That is so fantastic. And I will just tell the viewers and the listeners out there the way that we met at the FDA at that announcement of the black box removal, the black box warning off of estrogen. And I was sitting right next to Dr. Wittstein. So
yeah, I just happened to sit next to you, and here we
Wittstein.
are.
Yeah, I know. And I was like, who is this woman, this orthopedic surgeon?
And why are you at an announcement about estrogen at the
That's
FDA?
right.
Yeah.
But we had a great conversation. And, I will say, so before we get into all the medical stuff, I'd love to hear how you actually balance 5 children. Can you believe that, everyone? Does she look like she has 5 children? She has 5 kids, and I'm one of 5, so I know how hard that is for parents. So I'd love to hear a little bit how you kind of, balance your work life with your home life and just mental health.
This will sound crazy, but one of the keys to my ability, to be able to balance being a parent and work full time and being an educator and things like that is actually, crazy enough, being married to another orthopedic surgein. I know that makes no sense, but I truly think it helps to have if you have a crazy load, to be married to someone who fully 100% understands the exact load and stress that I have. So, like being married to someone who I can say to him, did you get to exercise today? Or he'll say to me, did you get to exercise today? Oh no, you need to go, because we know like what we're both living through each day. And so like, I can't imagine like not having a partner who didn't completely understand like the exact stress that I have. And so I know that sounds weird, but that is actually one of the keys. And, I have to thank my mom, because when my kids were young and I was working crazy hours, she was there for us and like was totally the glue in our family and helped us when they were really little. And for my own mental health, like exercise every day is, I cannot function without regular exercise. It is truly one of the most important things to me. And then I don't watch any TV and I don't golf, so I save lots of time there. So, just time management and a lot of multitasking, sometimes physical activity that I can pair with a mental activity. I try not to multitask too much with mental activities because that just doesn't work, but yeah. So,
that would be more stressful. Yeah, no, I mean, that's phenomenal. And I really appreciate all that you do. So tell me now, what led you to focus on female athletes and musculoskeletal health?
Well, I was a female athlete. I grew up being a gymnast my whole life. I was a collegiate athlete, and many orthopedic surgeons. And I think, for many orthopedic surgeons, one of the gateways to orthopedics is participating in sports as an athlete, because you're often exposed to someone who is injured, or you were injured, or you're exposed to the field of sports medicine. And it's kind of like the gateway sometimes into orthopedics. Although obviously orthopedics is multifaceted, and it's not just about sports medicine. I mean, joint restoration, microsurgery, arthroscopic surgery, there's just so much to the field of orthopedics. But um, so there's that. I've always, and I ended up specializing in sports medicine. So I do take care of athletes of all ages. But there are so many conditions within orthopedics that women are like uniquely predisposed to. It's not just in later on in life, but younger women are more likely, 8 times more likely to tear their ACL than boys and young men. And on the other end of the spectrum, we have things like frozen shoulder that is very, I don't want to say unique to, but like highly, highly, specific to menopausal women. And so I've just always seen or recognized conditions that are more prominent in women. And so, I'm in this field of sports medicine, but again, we're not just treating young athletes, we're treating people lifelong. So I think I've always kind of gravitated towards things that do affect women more than men, and just come at them with a different perspective, because only 6% of orthopedic surgeons are women. And so I think as a former female athlete, I have some, specific perspective, but it's just an area I've always been interested, probably because of my own life experiences, and then just being a woman and seeing women have, certain conditions impact them more than they impact men. It's just always been an area of interest of mine.
Yeah, that's amazing. And I'm so glad you're in this field, because you're absolutely right. It is pretty much male dominated. I mean, when I was in residency, I don't think I saw any female. I think maybe there was one, and I think she did like
Yeah,
hand.
yeah. There used to be a lot of women in, I mean, not a lot of women. It's not common, but in hand and pediatrics, and orthopedic surgery. But certainly, women are going into all aspects of orthopedic surgery now, and there are much higher numbers in training. It's just that it will take a long time, for the field to be equally represented.
Yeah.
Something like 250 years, I think, is the estimate based on current trends, which is possible someday, but maybe it'll happen faster if more
Yeah.
people go
Yeah.
into the field, or recognize that it's something they want to do.
Absolutely. So, you do a lot of research. And so, how much of your research is female focused? And when did you realize that women's bodies were under research? I mean, I'm sure that you probably realized that early on, but
Yeah.
when
Um,
did you?
yeah, I would say, I mean, sort of the first area that I started looking into was the, ACL tears, but just because they are so much more common in women.
No,
And
tell me a little bit about that.
yeah,
I don't know. Yeah.
so, the ACL is a ligament in the knee that helps stabilize the knee with athletic activities, where you're cutting, pivoting, think of soccer, basketball, things like that. Um, we still don't really know why women are more prone than men to tear their ACL. And there has been, actually, I will say, in many areas in orthopedics, there isn't a large body of research trying to necessarily focus on women or understand why women are more prone to something. The exception to that is there is a lot of literature actually trying to figure out why ACL tears are more common in girls than boys, or
Hmm.
men than women. And in a very frustrating way, we still don't know.
Oh, man.
There are a lot of
I thought you were going
theories.
to tell me, like, and we found out.
No, well, people have really, well, I'll get to what we're lacking, but people have looked at, is it the size of the ACL? Is it the amount of space, or we call it the width of the notch? Is it body weight, muscle mass? Is it the way women land versus how men land? And Are there different mechanisms of injury? And I've done some research into this myself, comparing, the different MRI findings and what we call bone bruise patterns in men versus women, and they ended up being nearly identical. Like just trying to figure this out. And we still don't really know. I do think that there is potential for it to be hormonally related. There are some studies showing that, for instance, women on oral contraceptive pills are less likely to tear their ACL. On the other hand, some of those are somewhat confounded by age and, why is someone taking an oral contraceptive? Maybe they're more, skeletally mature. There's one study that compared women using an IUD versus women on oral contraceptives and found no difference. So again, like even where we think we're kind of figuring something out, we don't have the answer. We've done some research that showed like some women's ACLs are oriented a little differently than men's, like a little bit more what we call vertical. But what we're studying now, which I think will really help get to the bottom of this, is we're looking at women and men in fatigued versus not fatigued states. And we have them do some jump landings, and we can make these three-dimensional models of the knee and actually see how much strain that their knee is under, but that their ligaments are experiencing. But we're also doing real-time measurements of relaxin and estrogen and testosterone. So we'll, hopefully get some more information there. But it's actually, that mystery is not solved, and we still need people to study it. And it is something that women are more prone to than men.
I had no idea. So that's really interesting to learn that. And so, do we know how much? I mean, I think you kind of mentioned this a little bit, but do we know how much of this is anatomy versus hormones versus training systems built for men?
Yeah, well, one concept is that maybe female athletes have some misfiring of their muscles, like the quadriceps activates more than their hamstrings, and this leads to, the injury, for example. It's possible women could respond differently to fatigue of muscles than, men do, perhaps. There's not clear literature about like timing of your cycle that you need to change your training necessarily, but that is actively being studied at the highest levels, looking at fatigue during different parts of the cycle. But it is such an area of active research, and deservedly so, because there are many long-term consequences of an ACL tear. People who tear their ACL are more likely to develop arthritis in their knee at a younger age than people who don't. And women are already at increased risk for knee arthritis. So if you have people who are athletic and they tear their ACL when they're like 15, when they are 30-ish, they may already have some signs of arthritis in their knee. And, and then they get to be midlife, where women are already more predisposed to arthritis because of likely some of the hormonal changes you experience in perimenopause and menopause. It's like these very athletic, active people can then be experiencing arthritis earlier in life for multiple reasons, if that makes sense.
Yeah. So, is there an age range that you found where these ACL tears were more common? Like, have you found that was it like in teenagers
Teens
versus
and early
newer?
20s are the most common,
Yeah,
for sure. Yeah. When people are participating in those at-risk type of sports,
right.
Yeah.
Yeah. Interesting.
Yeah.
And so, how do you think estrogen and progesterone affect ligaments and muscle strength? Do we know that?
Well, estrogen certainly, contributes to collagen synthesis, and it can contribute to like the organization of ligaments. But on the other hand, also contributes to laxity and flexibility, right? And we know, like for instance, in the shoulder, the capsule of the shoulder, when women go through perimenopause and menopause have declining estrogen levels, that's getting, stiffer and tighter. We generally don't get more like flexible as we get older. We tend to
Yeah.
to
No.
to lose flexibility. And ligamentous laxity is a double-edged sword. We see many young female athletes, for instance, who have hypermobility of their shoulder. Having laxity is, there's benefits to that. It means you're very mobile and flexible, but on the other hand, it can contribute to instability. So people who have
Mm.
loose ligaments also need to be quite strong. You have to rely on muscles to stabilize joints that are what we call like ligamentously lax. So I think having integrity of ligaments that are also flexible can be what allows for excellent mobility. But estrogen is also an anti-inflammatory hormone. So as we get older, if our joints get a little bit stiffer, but then they also get more inflamed, you can get some loss of mobility and then joint pain, and you're kind of going in the other direction. So.
Yeah, I mean, I think that, and as you also, you were talking about joint pain in midlife, but that's such a common symptom of
Mhm.
perimenopause and menopause as we get older, and it's so important to keep exercising and keep moving those joints. Um, I've noticed that, estrogen is so important in different parts of our body for lubrication, but like specifically for joints, what would you say with estrogen? I think you talked a little bit about that.
Yeah, I mean, depending on the study and the data you're looking at, women over 50 are approximately 35% more likely to have knee arthritis than men, for example. And that difference does not go away until about age 80, where men have, just further wear and tear. But some of that is, likely related to the fact that there are estrogen receptors in the synovium, or the lining of the joint, the cartilage, the bone right underneath the cartilage that supports the cartilage, which is the smooth gliding surface of the joint. Estrogen is an anti-inflammatory. We know from like the SWAN data, for example, that inflammatory cytokines do become more elevated as estrogen declines. And that has systemic effects, all over the body. And one of the areas that can affect is our joints. And we definitely see that women have this spike or this increased rate of joint pain. That, again, arthritis becomes more prominent in women in their 50s as compared to men's. The cartilage can become thinner. And it's not just knees, multiple joints can be painful. And we certainly know from studies out of the Women's Health Initiative, upwards of 75% of women reported some joint pain, and with interventions that included estrogen therapy, in that case, Premarin, there was significant reduction in joint pain, and then with removal of that therapy, some rebound in that joint pain. And there aren't studies that clearly show that if women use menopausal hormone therapy with estrogen, that they are less likely to need a knee replacement. There isn't that strong of data, but there seems to be this side benefit of these medications, in terms of reducing inflammation and joint pain. It's of course not an FDA indication for hormone therapy. It's not, but preventing osteoporosis is,
Yes.
but not
Yes.
joint pain. Yeah.
Yeah. So do you, I mean, I guess if I was to, let's say I was your patient and we're talking about how to maintain strength. And I've seen on Instagram, you show like exercises that you should do. And for those listeners out there that are not already following Dr. Wittstein, that you really should, because she does go over some exercises and tells, how to move the joints and what you should be doing and what kind of exercises. But what do you think would be like the ideal, let's say, exercise regimen for a woman in midlife?
So multifaceted, but number one, we do need to do strength training 2 or 3 days a week. And you will hear you must lift heavy, you must lift heavy. And I do like to always emphasize when we're talking about strength training that heavy lifting is not for everyone. In many cases, it will be safe. And the really high intensity lifting where you are, doing some large amounts of weight to the point that you can only lift 4 to 6 times, 4 to 6 repetitions in a set before you are maximally fatigued and can't do another repetition without good form. That's high intensity strength training. That is more effective for maintaining bone density than moderate or lower intensity strength training. But if you do the moderate intensity strength training at higher repetitions, you still will get bone health benefits. People have limitations like arthritis, tendonitis, maybe you had a rotator cuff tear. So I always want to emphasize, when you hear the message about lifting, it would be great if you could do the higher intensity, but if you can't, that's okay. So we want to do some strength training a few days a week. And the strength training needs to include certain types of exercise maneuvers, ideally things where you are carrying the weight in the way that's going to load your hip and spine. So the classic maneuvers you hear about are deadlifting, squatting, and overhead pressing. And those come from a trial called the Lift More trial. But you could also do things like farmer's carry, something where you're carrying the weight. So that's strength training. That's number one. there is another mechanism to promote bone density, and that is called mechano-transduction. So that's some form of jumping or impact. And again, this isn't for everyone. So I always list these things like on a menu. But in a perfect world, if you didn't have, arthritis or other limitations to jumping, like people with prolapse will often say, I can't jump, that kind of thing because of incontinence. But if you can jump, you don't have to do a ton of jumping. You could do, 20 jumps a day. There's one study that showed if you did 30 jumps a few times a week, that's effective for stimulating bone density, especially in the hip region. This could be simply jumping off an 8-inch step with a rebound. It could be a big squat jump with a rebound jump. If that causes you to have incontinence, if you have prolapse, you could do something less intense. There's one study that showed you can create significant ground reaction force with just moderate intensity stomping, or something called a heel drop, where you go up on your tiptoes and sort of drop down onto your heels. So that's our second set of type of exercise, is some sort of impact that creates a mechanical force called mechano-transduction that stimulates bone growth or bone density in our hip region. So then, aside from that, it's good to work on balance because we don't want to fall. That could include yoga. It could include just simply, like brushing your teeth, standing on one leg, switching sides halfway between, just incorporating balance work into your daily life. Ideally, a little bit of agility training so that you also don't trip and fall. This doesn't have to be super high intensity. I have a video on Instagram of just like even a simple agility ladder on the ground. Something where you're doing some fast foot movements just to kind of maintain some of that ability to respond to your external environment. So we got the strength training, the impact, the balance, a little bit of agility work. And then what I don't want to leave out is, cardiovascular exercise, because cardiovascular disease is still the #1 killer of women. And so I really like the research of Dr. Ben Levine, who is a cardiologist who really, his work is the origin of all this talk you hear about, making sure you include your Norwegian 4x4 1 or 2 days a week and how it reverses your heart aging. That comes from his body of literature. But basically,
I don't know about that. What do you,
Yeah.
can you just tell me what you're talking about with the Norwegian?
Oh, yeah. So again, it's really important for people to get in cardiovascular exercise. Like, I think people get this message that when you're a perimenopausal or a menopausal woman, like, stop doing all that cardio, you just need to strength train. But cardiovascular exercise is really important for your heart health, and also certainly contributes to prevention of dementia. A Norwegian 4x4 is a form of high intensity interval training. And in a Norwegian 4x4, you are doing basically 4 times 4 minutes of intense cardiovascular exercise. You're exercising so hard you can't like speak in full sentences. And then you do 3 minutes of recovery. It could be like rest or active recovery. So, and then you repeat this 4 times. And this is one of the key components for improving your VO2 max. And then, the other aspects of your cardiovascular exercise for the week could be sort of zone 2. It could be brisk walking, 30 to 40 minutes a few days a week, and then one endurance day where you're doing 45 minutes to an hour of something. It could be dancing, it could be walking, riding a bike, but something where you're getting endurance in. This is for your heart health. But, people get really intimidated by the concept of a Norwegian 4x4. I usually do mine on Mondays after work. I try to do 1 per week, so I earmark usually Monday evening to do it. Dr. Levine's research, they did kind of either do 1 or 2 days a week and part of that protocol, but it doesn't have to be running. People think you have to sprint. Like, it doesn't have to be running. I do mine on an air bike. You could do it on a rowing machine. You could do it on a stair stepper. It's just, these 4 minutes where you go as hard as you can, 3 minutes of recovery. And you get through it and you feel really good at the end. It's while you're doing it, you're like, I hate this. But when you're done, you feel so good. So, but that's what a Norwegian 4x4 is.
Well, that's fantastic. I had no idea. I'm going to have to start mine tomorrow.
Yeah.
Have to figure that out.
Yeah. And then once you get used to it, and the beauty, I love a Norwegian 4x4 because you get through the first one and you're like, that was really hard. And then you get through the second one and you're kind of like, I'm halfway, and you're like, okay, I can do another one. And when you finish the third, you're like, I just have one left. And you get the recovery in the middle. So, it's actually quite doable. People are really intimidated by it, but it's so doable. And it is really good for your heart health.
Yeah, I'm going to have to try that. It sounds fantastic. So So we often, I don't, so you know what somebody told me today? So I was doing this podcast earlier in the morning, and somebody mentioned that strength training was really good for libido. And I'm trying to remember why she said that. She said something, oh, because it increases your testosterone. Um, I know you're looking
Yeah.
at me like, what?
Yeah, I mean, I guess that's probably true. I haven't I mean, I'm sure there are studies on libido and strength training. I think in general, strength training has so many benefits. Much like cardiovascular exercise can increase circulating hormones like BDNF to help with our brain. Strength training can increase circulating levels of irisin, which also goes to our brain and can help with cognitive function. I think endorphins are generated by cardiovascular exercise and strength training. Certainly, maintaining more muscle mass helps with your metabolic health. Lean muscle mass is directly correlated to bone density in menopausal women. Strength training increases your bone density. There are just tremendous benefits to strength training. But one of them, which is, I think, maybe not the one we think of the most, is as women go through hormone changes and you get changes in body composition, people just don't look like what they're used to looking like anymore. Gaining muscle mass, I think, does give people confidence too. And not that I'm in any way saying what people should look like. And I think I'm not a person to talk about what people look like and what their body looks like. And I'm definitely not telling people to strength train to be happier with the way they look. But I think it's pretty common for people to feel better about themselves when they are stronger.
Yeah,
And
no,
maybe that affects
libido.
intimacy.
Right. No, no, no. But I think you're absolutely right. So, that's something that is very, very common, which is, our body image, right? And
Hmm.
that's one of the causes of low desire. So, regardless of whatever it is that you're looking like, as long as you start to exercise and move your body, you're going to start to feel better because of the endorphins. And when you feel stronger,
Mm.
right, you're going to feel better because you're feeling like you're doing something for
Yeah,
your
more
body.
confident. Yeah.
Right, absolutely, and I always think about, what is it that I wanna look like when I'm 90 years old, right? I mean, I hope and pray that I'm not sitting in a nursing home waiting for someone to take care of me, right? I hope that I can at least take care of myself and take care of my own needs and, be able to walk and things like that. So, I think that, and then I always think about, would my future self thank me for what I'm doing right now, you know? And so I'm always trying to look toward the future. So I think that, what you're saying is very pertinent. I think that, how people feel about themselves is always definitely going to impact, how they feel. If you feel good about yourself, you're going to feel good with your partner, right? Because love always starts with yourself. So I agree with you 100%. Do you think, that injury and chronic pain can affect somebody's confidence and intimacy? I mean, what happens when we have this chronic pain, probably due to maybe arthritis or, all the changes that we're going through in midlife?
Well, I mean, I think chronic pain and depression can also go hand in hand,
Yeah.
and um, and probably feed off of each other a little bit. Um, and and sometimes chronic pain isn't even well understood. Like fibromyalgia, which is almost exclusive to women, for
Yeah.
instance, has been associated with low progesterone levels, for
Yeah.
example. But yeah, I think that there can be mood associated with chronic pain and just generally, I don't know, it's like a chicken or the egg, but there's also, diminished activity sometimes or interaction with others and isolation and
Right.
yeah, so and then depending on what's painful, maybe you have a lot of back pain or hip pain or not mobility around your pelvis, or maybe things that are actually just uncomfortable with
Right.
with intimacy.
Right.
Um, so,
Absolutely.
there are actually certain conditions, actually a lot of hip conditions where one of the presenting complaints is that women can't be in certain positions or don't tolerate intimacy because of their hip pain.
Sure.
Um,
Makes a
and
lot of
then
sense.
sometimes those things are improved with procedures, surgeries that are addressing the hip pathology. And then likewise, there are sometimes restrictions after certain orthopedic surgeries where you have to be
Right.
careful with the,
With the
positioning of hips.
positioning. Yeah. Yeah,
So you
absolutely.
don't cause a hip dislocation or something. So,
Right. That's never a good thing.
yeah.
Tell me, what are the most common conditions that you see in your practice for women in midlife? What do they, what are they coming in complaining of, or what are the things that you're dealing with?
Yeah, I mean, definitely the top two conditions that midlife women present to my clinic with are frozen shoulder and then new onset knee pain, but with pretty normal looking x-rays. So frozen shoulder definitely is, I would say, is essentially, recognized as a symptom of perimenopause and menopause at this point. And the knee pain is usually, women are also at this phase where they're saying, okay, I need to strength train. I need to do some of this jumping. I need to be more active. I need to build more bone density, but also, maintain my lean muscle mass, which is declining. And a lot of people are being proactive about their health and just trying to do more, but occasionally will then present, sort of the increased activity is corresponding to also their hormonal changes, which make their knees more vulnerable. And they're like trying to go run a half marathon, but then their knee is swelling. And so it's a little bit of a bad intersection. I actually think it's a horrible irony in general that women are prone to both osteoporosis and more joint issues and arthritis at the same time, because some of the needs of these conditions are a little bit fighting each other, right? Like if we want to do impact and this heavier lifting and all this, but your knees are hurting, it's kind of like this very unfortunate intersection where you're battling joint pain, but also trying to build bone density at the same time. So we're trying to find workarounds. It's an interesting sort of conflict of things we'd like to be able to do for ourselves.
Yeah, for those people that don't know, may not know, or are lucky enough not to know what frozen shoulder is, maybe you could just tell us a little bit what
Yeah.
that is and what exercises you would recommend to help overcome frozen shoulder.
Yes. So frozen shoulder is a sort of sudden onset of shoulder pain and then stiffness that is brought on by really no trauma. I mean, this is atraumatic. It's been referred to as idiopathic. Of course, it was labeled that way for many, many years in the field of orthopedics. And even if you look at the old literature on frozen shoulder, there are even papers describing women who have this condition as being histrionic. And it's all stemming from the fact that it's almost entirely a condition that affects women typically between the age of 40 and 60. And it does seem kind of crazy because, you didn't do anything. You just woke up and your shoulder was stiff and painful. And it usually starts with really bad pain and then rapidly can progress to like loss of range of motion. So stiffness, hence the name frozen shoulder. And, one of the first ranges of motion people will lose is they'll lose some of their like rotation out to the side. So let's say I could bring this one all the way out to here, but this one only goes that far. It's a loss of range of motion. The first thing people will say or really notice is they can't reach behind their back to fasten a bra or tuck in a shirt. Then they start to lose motion up overhead. So you're losing range of motion in all these planes. It's very painful. It is most likely caused by hormonal changes with dropping estrogen levels. We know there's a mechanism through which estrogen inhibits a cell type called fibroblasts, which are the cells that sort of thicken and make the lining of the joint tissues like less flexible. And so the shoulder joint becomes inflamed and stiff, and then eventually it sort of burns out and just becomes frozen and thaws out. But this whole process could take a couple of years, if not interceded with like early on. And you will hear, move it, push through it. You got to keep it moving, get into a physical therapist. And I love my physical therapist. But I will tell you very frequently, if someone is in that inflammatory phase of frozen shoulder where it's extremely painful through the arc of motion, that is not the time when physical therapy helps. And actually, a physical therapist will often say, hey, you need to stop coming to me, go see the orthopedic surgeon and get a steroid injection. Because when physical therapy is really helpful is when we get rid of the inflammation and then the person can tolerate the movement with physical therapy and then they can make gains in their range of motion. So for me, the first goal is, yes, we do want you to keep moving it so it doesn't freeze up. But if having someone move your arm like through the range of motion or to the end range that you have is causing worsening pain and you're getting worse, like that's not the time to fight through it and push really hard. It's a better time. It's the best indication there is, in my opinion, in all of orthopedics for a steroid injection in the shoulder joint, because you can stop the inflammation and then you can get back into physical therapy and then you can work through it and then it can thaw. And sometimes you need 2 injections, but that's I just think a little bit of a nuance that I want people to understand is that if you're going to physical therapy and it feels worse for it, it's not that your physical therapist is doing something wrong. It's just that you're maybe not in the right phase of the frozen shoulder to benefit the most from the physical therapy.
Got it. Yeah, yeah. I'm surprised they didn't call it like senile shoulder or something, right? It's like senile women's shoulder.
Yeah. There are some Asian cultures that basically have a general name for a frozen shoulder. They just call it 50-year shoulder. And women just expect to get 50-year shoulder. And like I had frozen shoulder about a year ago, and I am an orthopedic surgeon that studies, I've done research on frozen shoulder. I work directly with women's health. And of course I knew when I got it right away because I could tell exactly what it was. I was very in tune with the fact that I all of a sudden didn't have the motion. It was very painful. And so I had a steroid injection and I've done, the range of motion exercises. But like, even with the most attentive early intervention, I will tell you, I'm about a year out, it still takes a little time. I have all of my forward flexion and all of my rotation, but it's still a little tight behind the back. Like not, this one can go all the way. This is a little tight. So it takes time and it gets better. But, the best thing to do ideally is get a steroid injection in the glenohumeral joint, in the ball and socket joint, very early in the process, ideally before it gets really stiff, and then work through the range of motion.
Such good information.
Yeah.
Would they ever consider, PRP, platelet-rich plasma, for something like that?
So you could do that, but platelet-rich plasma doesn't have as much of an anti-inflammatory effect or as quick of an effect. And you're really wanting to reverse this process, hopefully pretty rapidly. So again, there are many cases where I tell people avoid steroid, but this is not one where I tell them to avoid it because it can really turn it off and really reverse it really quickly. I have had like so many women just come back after that injection and ask to give me a hug because they are so dramatically better. And for so many women, that is all they need is 1 steroid injection, maybe 2. And it just keeps them from going down the extremely frozen path where it's just really socked in.
Yeah.
And it's not a Band-Aid for the problem. It's more like a cure. There are other things where steroid is just a temporary, like a Band-Aid effect, but this is really helping to stop it before it gets so much worse.
It almost sounds like timing is of the essence with frozen shoulder, like to get
I tell people and then, the people that have it on one side, when they start to get it on the other, which is not infrequent, they know so much sooner, they come in sooner, we do the injection sooner, they don't get so frozen, and it just kind of nips it in the bud. But it's pretty common for people to get it on the other side as well.
Yeah, that's such good information. I had no idea.
Yeah.
So what top 3 habits for lifelong joint health would you give women, somebody that's listening to this episode and just trying to learn as much as they can about their musculoskeletal system?
Okay, so for joint health, it's much like your bone health. It's really important that you maintain muscle mass in your legs because people who have weak quadriceps always have more joint pain, especially around their patella or kneecap region. So just like with bone health, with joint health, maintaining your muscle mass in your legs, hips especially, and thighs is extremely important for diminishing your knee pain. The next step, which is extremely hard for some people, and I completely recognize it, but I have to say it because it is frankly the only thing that slows progression of arthritis, is maintaining a healthy body weight. So being overweight, obesity really contributes to your risk of arthritis, not just in your knees or lower extremity, but actually any joint in your body because of the inflammatory state associated with that. So people with obesity are also more prone, for instance, to getting arthritis in non-weight bearing joints. So if you're overweight, weight loss, even 10 pounds will reduce your knee pain, but maintaining a healthy body weight can help slow the progression of arthritis. And I fully recognize whenever I speak to a patient about this, that is an incredibly difficult process. especially when exercise is one of the tools that we use for weight loss. It's just really hard if your knees are hurting. But thankfully, a lot of these medications are available now. GLP-1 medications are making this, more feasible to people. That gets to a little bit of the intersection with point number one. If you're using GLP-1 medications, it's really important to do strength training along with it so you don't lose lean muscle mass. Yeah.
Yes.
So strength training of the hips and thigh muscles, trying to maintain a healthy body weight. And then number three is listen to yourself. So we know the importance of cardiovascular exercise. I have many, many patients who start their, fitness journey at some point as a runner. And then at some point along the way, they start to develop knee swelling. And it's not that running, for example, causes arthritis, because there's a lot of evidence that it doesn't. But for people who have knee arthritis, high impact activities can cause swelling of the joint, which is kind of a sign that you're overloading your joint cartilage. So it's not normal to have fluid on the knee or for your knee to be big and swollen and full of fluid. So when I say listen to yourself, we may have to choose your cardiovascular exercises wisely. It may be that we need to transition from running to biking, rowing, walking, cycling or swimming, things like that to maintain your cardiovascular exercise. But we don't want to be routinely causing your knee to swell, because that's also going to make your quadriceps atrophy and not function very well. So sometimes there is this, I just tell people, like, aging of your joints can be a little bit like, when you're a kid and you have an injury and you have to work around it. Aging is just a bunch of injury obstacles you have to keep working around because you have to keep moving. And so sometimes we have to adapt and do different things. And if we are then needing to choose cycling or swimming or lesser impact forms of cardiovascular exercise, we still need to keep in mind then that we need to, again, do the strength training or find ways to do things for our bone health. Because, for instance, cycling is not going to do anything for your bone health. It's a great cardiovascular exercise option for our heart health if we need to alter our impact that we're doing because of our joints, because we need to respect our joints. But if we're changing our cardiovascular activity to something that's not weight bearing, we still need to think about, doing the other weight-bearing activities more in the form of strength training, for our bone health. So it's really impossible to separate bone and joint health. Sometimes people talk about joint health, they talk about bone health, but they're, we have to think about them both, because you need your joint health for mobility, but you need your bone health to hopefully not, get a hip fracture as you get older.
Yeah. I'm like trying to take all these mental notes while you're talking. I'm like, oh my God, I need to remember so much stuff.
So that's where I actually, my book, which is.
Tell me about your book. Tell us all about your book.
Yeah. It's called The Complete Bone and Joint Health Plan, and it's co-authored by my lifelong friend and former gymnastics teammate, Tanita Skorsky, who's a registered dietitian. But it's just, I don't think, I think to comprehensively think about your musculoskeletal system, you can't really think about your risk for osteoporosis without your joint health as well. And so I try to kind of always think about both. And they're related, like we talked about earlier, women are more prone to arthritis and osteoporosis. These are both conditions that are somewhat driven by inflammation. Some of the same processes that lead to bone breakdown are also some of those processes that contribute to cartilage breakdown. And that's, probably why women are more prone to these conditions, because menopause is a more inflammatory state. The withdrawal of estrogen is an inflammatory state in some ways. So, there are a lot of common pathways between osteoporosis and arthritis, and women are more prone to both. But there are also a lot of diet and exercise and lifestyle choices you can make, to help manage symptoms of arthritis, make you less likely to be symptomatic from it, and things you can do to be less likely to go on to develop osteoporosis. For even those people who cannot use hormone therapy, because obviously there are people who can't for various reasons or choose not to. So it's one of these things where, yes, I think hormone therapy that includes estrogen specifically is definitely protective of our bone density and probably makes our joints happier. I think progesterone contributes to pain relief, I think. But there are certainly people who can't use estradiol. And whenever we talk about the benefits of estradiol and women being more prone to arthritis and osteoporosis because of that withdrawal, I don't want to leave out that population. But there are sometimes just sometimes that's not on the table for some people.
Yeah. Yeah. And do you have recipes in your book?
We do, yes.
Ooh, so
Yeah.
I'm definitely gonna order that today, your book.
Yeah. So we try to blend together, much like how we were talking about how sometimes you have to make compromises for an unhappy knee or unhappy joints, but you still need to then figure out, okay, how are you going to load your bones? How are you going to stimulate bone density? How are you going to maintain your bone density? I feel like there's a little bit of sometimes conflicting, when you're thinking about, okay, how am I going to eat the right way, for bone health versus what do I need to do in my diet to have a less inflammatory diet that something
Yeah,
that might help my
heart
joint
health.
pain.
Yeah.
So I think
Mhm.
I try to like kind of blend and wed that all together. So we include description of an anti-inflammatory diet, but also all the components of your diet you need for bone health, and it's just like a lot to think about. And so then we sort of synthesize those things into various recipes. And
Amazing.
yeah, so that's where that came from.
It's fantastic. So tell me, what you think is the biggest myth that women have about strength training?
Oh, there's certainly a fear of becoming too bulky, looking
Yeah,
like a man, and it is so hard to get bulky.
I
I,
wish.
my current muscle is a shadow of my former gymnastic self. I wish I could be. I mean, I could probably spend more time in the gym. I just don't have endless amounts of time, but it's really hard to become too bulky, or certainly I wouldn't mind being bulkier, but it's just, that's definitely a myth, I think. And so, yeah, you're not going to get easily bulky or man-like if you're concerned about that. And I think actually a lot of people would like to be bulkier, but it's just not that easy. And as we age, it does become harder to maintain our muscle mass, and we have to work a little harder at it. Both men and women do. And uh, I just think people are becoming more and more aware of the benefits of strength training, both metabolic health, bone health, brain health, mental health. But it's quite hard to get bulky from strength training. Yeah.
How do you think testosterone impacts muscle mass? A lot of people want to go on testosterone for, the indication, right? The off-label indication.
Yeah, I mean, I think at super therapeutic levels, it's going to increase your muscle mass, but within normal ranges, I think you're probably more likely, the effect on your muscle mass is more likely going to be actually just being consistent with the strength training program. Oh, but one of the myths about strength training, though, I do want to go back to that, is that, again, I really want to emphasize, and I want people to really understand that um, you don't have to lift at the highest intensity to have the benefits of strength training. And I
That's
just
really important.
emphasize that
Yeah.
because I see a lot of people who end up injured. And certainly
Yeah.
there are ways to progressively strength train and build up from the lower intensity to the moderate to the high intensity. But it's okay. And the example I always give is, for instance, I'm never going to be a high intensity overhead presser because I always get tendonitis if I do that at a high intensity. So I make the choice intentionally of being a moderate intensity, higher rep person for overhead pressing because it's worse for me to be out of commission and injured with tendonitis for several weeks than, there's more benefit to me being able to regularly strength train without injury. And I don't want people to feel bad if they can't do something at an intensity of like, just 4 reps and, 85% single rep max. Like it is great if you can, but also give yourself, the option of the less intense form of strength training at higher repetitions because there's still a lot of benefit to that.
I'm so glad you bring that up because, as somebody that always throws out their back
Yeah.
every time
Yeah.
I try to lift heavier weights, it's good to know that I can still get the same benefit with lifting not so heavy weights, but
But
still,
higher
being
repetition, so you
consistent,
still get to the
high
fatigue at
repetition.
the end of the set.
Yeah.
And that sometimes is more sustainable for people. And if something is more sustainable and you can do it more regularly and then you're not injured and taking time out from the strength training, that's going to be more beneficial for you. So it's not really like myth busting. It's just sort of helping people understand that they can cater their strength training regimen a little bit more to their own individual needs. Maybe you have a bad knee and you can't squat deep, for example, or really heavy. So just, I think, working around injuries and recognizing sometimes we have some limitations that don't go away, and we just need to work around them.
Yeah, yeah, absolutely. So if you could leave, our listeners and viewers with one message about strength and aging, what do you think that would be?
That it's really never too late to start. There's so much of a sense that if someone hasn't started strength training, or they weren't doing all the things before the age of 30 or before the age of 50 to prepare themselves for midlife, so they arrive to midlife with all this bone density, that it's too late. And I just think, recognizing that it's not too late to initiate strength training, and to do so in a safe way with a progressive increase in strength training. Take some hope in from the fact that there are multiple studies on postmenopausal women where the interventions are started in their 60s, where people are able to progressively gain strength and improve their bone density. So I guess the message is it's not
Yeah.
too late to start strength training.
Yeah. And that is such an important message, right? Because you're exactly right. I feel like a lot of people are like, well, it's just too hard for me and it's too late for me. And I already have osteopenia or I already have osteoporosis and nothing's going to help. And I always like to
Yeah,
leave
you want to
people with
slow that down
hope.
or turn the
Yeah.
ship around a little bit. Yeah.
Yeah, exactly, exactly.
Yeah.
So it's fantastic. So for, all those people that are listening and watching throughout the world, they're watching you, and they're like, wow, she is amazing. How can I follow her? How can I buy her book? Where can I see her? How can they get in touch?
As you know, my 20-year-old daughter helped me start an Instagram page about a year ago, and I do share a lot of bone and joint
Amazing.
health information there. And it's just my name, Jocelyn_Wittstein_MD. I'm not tech savvy enough to be on other platforms like you. And then our book, which is called The Complete Bone and Joint Health Plan, is on Amazon or Barnes and Noble. And I just want to emphasize the reason I started that project and then brought in my friend Sydney, and then we completed it, was just that I just so badly wanted to have all this information in one place. And I'm not saying this as a sales pitch or something. I'm so
Oh, but I do
grateful.
want it to be a sales pitch. Go
Yeah,
ahead.
no, I'm so grateful that so many people have sent me so many sweet messages of how helpful it's been to them.
Yes.
And
It's
you know,
transformative.
yeah, well, my husband is like, I can't believe you're spending all this time doing. I mean, he's very supportive, but he's like, this seems like a lot of work for. There are people even going to buy this? I honestly don't care if anyone buys it. If anyone finds it helpful, I love it. I don't. It was completely a passion project for me that I just really wanted to complete, and I had so much fun doing it with my good friend. And if you do buy the book, you'll see we are the models and the exercises. It's not like these are for everyone. It's a very low barrier to entry. And I think it's a very approachable book for people who just want to understand their musculoskeletal system and their bones and joints, and kind of get started if you haven't started, or if you have started and you just want more information about how exercise and diet can be used alongside medical interventions. So.
Amazing. I love it. Well, thank you so, so much, Dr. Wittstein. Right?
You got it. You have a
Yeah.
50-50 chance of saying it the right way.
Yeah, I know, I know. And then I was like, okay, Frankenstein,
Yeah, right.
Wittstein. Okay, got it. Focus. Yes.
Yeah.
Okay. So this was so amazing. You are amazing. Thank you for all that you do. I'm going to go and buy your book because I think that is going to be so helpful for so many people. And I'm going to keep it in my office so I can refer to it, but also tell people about it, because I think that, just as you were saying, they think that perhaps it's too late, or maybe I'm going to become too bulky. And the fact that you have recipes in there, it's so hard to figure out, like, gosh, what can I eat? Maybe I can't eat anything. How am
I
I going to
know
lose?
it's too complicated
Yeah.
sometimes, and
Yeah.
it doesn't have to be that complicated. Yeah.
Yeah. Yeah. So I'm really excited to take a deep dive into your book. So that's fantastic. And well, We are done here, and it's been real and really intimate. And remember, this is not meant to be any type of medical advice. So if you're having any issues with your joints, your ligaments, your bones, any of that kind of stuff, make sure you go see your healthcare provider. And until next time, this is the Muslim Sex Podcast. So thank you for listening to the podcast, and make sure you leave us a review, share and like the podcast. And if you leave me a review, I'd love to shout you out on social media. So be sure that you share it with all your friends. And thanks for listening.